All right, good morning, everyone. Welcome to our talk, How to Lose Clients and Confuse People. Thanks for choosing our talk on the use of behaviourality principles to build trust, rapport, and professional relationships in the context of trauma-informed care, especially when there are lots of other good talks to choose from. And thanks to PBS UK for hosting this conference. Okay. We work in a mental health clinic in the south of Wales called the Behaviour Clinic. Barney is a behaviour analyst and the manager of our residential team at the clinic. He supports residential homes to implement trauma-informed care. Krista is a behaviour analyst in the Tribe team at the Behaviour Clinic. She specialises in working with parents and carers of care-experienced children. She supports families by implementing strategies through utilising behaviour analysis and trauma-informed care. I'm Ethan. I'm an assistant behaviour analyst, training as a UK BA cert. I work in the Behaviour Clinic's class team. I provide therapy to children and consultation support to carers, parents, and teachers. So what will you get from our presentation today? I'll talk a little bit about who we are at the clinic. I'll talk about ACEs, trauma-informed care, ACEs, trauma and trauma-informed care. My colleagues will talk about some cases where behaviour analysis and PBS were applied in a mental health setting and reflect on what they learned from their mistakes. We'll sum up our presentation and have some time at the end for questions. Please use the chat and we'll respond to this at the end of our respond to any questions at the end of our presentation. So before we begin, I want to take a moment to offer a sensitive pre-warning. Some of the topics we'll be discussing today involve significant childhood trauma, including experiences around substance abuse, domestic violence, and sexual abuse. To respect confidentiality, the identities of the cases we present have been altered. In our work, despite the safeguards we put in place, mistakes are inevitable. However, we believe that growth, learning, and professional development come not from avoiding mistakes, but from acknowledging them and improving because of them. This presentation is an opportunity to reflect not only on the lessons we've learned from our past mistakes, but also on how mistakes, when handled with humility and courage, can shape us into better professionals. We invite you to engage in this discussion with an open mind and consider how your own experiences, both challenges and successes, have contributed to your professional growth. As the saying goes, mistakes are always forgivable if one has the courage to admit them and learn from them. So the title of our talk today, How to Lose Clients and Confuse People, is a playful twist on the famous Dale Carnegie book. We hope that many of you attending today have heard of it or perhaps have even read it. Soft skills are a crucial component of working with a team to achieve the best outcomes for vulnerable individuals. Even 89 years after its publication, we do believe that the principles outlined in Carnegie's book are just as relevant, if not more so, today. Throughout the presentation, we'll touch on both direct and indirect aspects of soft skills. You'll see the principles we find most powerful woven into our slides and discussions. And if you haven't read the book yet, we highly encourage you to pick up a copy. It's a timeless classic for anyone working with people. So who are we and what do we do? See on the left a video that shows what our clinic in Cardiff looks like. The Behaviour Clinic is a mental health clinic based in the south of Wales. Most of us are people with a background in ABA, although there are also play therapists, life story therapists, counsellors, psychotherapists, and graduate psychologists who work here. Our work is informed by attachment theory and trauma-informed care. We work with children with histories of exposure to adverse childhood experiences who are care experienced. We provide trauma-informed care and therapy support to children, families, and carers, as well as training and consultations to organisations such as schools and residential homes. So I'll talk a little bit about what adverse childhood experiences are. We can distinguish between three kinds of ACEs: abuse, neglect, and household dysfunction. ACEs are associated with negative mental health outcomes, such as increased risks of mood disorders, anxiety disorders, psychosis, personality disorders, a risk of suicide attempts, and self-harm. ACEs are also associated with negative physical health outcomes, e.g. cancer and heart disease. So what are the differences between ACEs and trauma? Sometimes people will use words like trauma and adverse childhood experiences interchangeably, but we'll be using the term ACEs to refer to things that happen to children. ACEs are negative experiences occurring from birth to the beginning of adulthood. Adverse childhood experiences can include a variety of things, including verbal and physical child abuse, sexual abuse, the presence of drug and alcohol abuse, parental mental health difficulties, family members dying by suicide, family members going to prison, and other things. Here's a clip from Laura, who is a behaviour analyst and a social worker and the clinical director of the Behaviour Clinic.
What's the difference between ACEs and childhood trauma? Well, ACEs, or adverse childhood experiences, are stressful events that happen during childhood. These ACEs can be things like abuse or neglect or witnessing domestic violence. Childhood trauma is the impact that these events have on the child. So children can have a heightened fear response, they could have difficulties forming attachments, or difficulties forming social relationships, or they could have some medical needs that result from these ACEs. The terms adverse childhood experience and childhood trauma are often both used together, but what it's important to remember is that the adverse childhood experience is what the child actually experienced. The trauma is what comes after. It's the result from those adverse childhood experiences. So that could be that heightened fear response, it could be the difficulties connecting with friends, but that's resulted from that adverse childhood experience, and sometimes that's referred to as early life trauma. Keep swiping for more on adverse childhood experiences and childhood trauma.
So there's no consensus as to how best to define trauma, but most sources will conceive of trauma as a response to frightening or distressing events. Trauma results from incidents or series of incidents that are perceived as disturbing, life-threatening, or impairing. Trauma can have lasting adverse effects on individual functioning. It has been estimated that about 60% of men and about half of women are exposed to at least one traumatic incident in their life. We can make distinctions between 3 different kinds of trauma. Acute trauma is a result of a discrete incident, for example, a car accident. Chronic trauma is the result of something repeated over an extended period of time, such as exposure to long-term abuse. Complex trauma involves a combination of chronic and acute trauma. For example, a young person experienced the deaths of family members, while over a long period of time, domestic abuse is occurring at home and bullying is occurring at school. Trauma-informed care underpins the work we do at the Behaviour Clinic. Where possible, we hold ourselves accountable to the 4 commitments outlined within Rajaman et al.'s paper. This involves acknowledging the effects of ACEs that ACEs have on children that we work with, for example, by reviewing available information about ACEs that they've encountered, assessing their therapeutic needs, and developing relevant clinical formulations. Building safe and trusting professional relationships might involve assessing relevant preferences, identifying the therapeutic goals relevant to their needs, and pairing with clients so that engaging with us is reinforcing and meaningful to them. Promoting choice and shared decision-making may involve clients choosing therapeutic goals or ensuring that the values that are important to them are that they inform therapy as appropriate. Building skills might involve interventions such as behavioural skills training or DBT skills modules. Thank you for listening. I'm now going to pass you on to my colleague Krista, who will discuss our practice example.
Hi everyone. Thank you for the introduction, Ethan. That was lovely. So as Ethan said, my name is Krista and I'll be taking you through a practice example. So I hope that you will see the trauma-informed care commitments throughout parts of this example that I'm going to discuss today. So I will be presenting a practice example of Dale, and in keeping with the theme of confusing people, Dale is a 15-year-old female. So throughout this presentation, I will be addressing several key points. So I will be discussing the challenges faced when working with this population, the specific difficulties I encountered while working with Dale, how I attempted to address these challenges whilst reflecting on the strategies I employed, and acknowledging that in hindsight, some of these approaches may not have been the most effective. So by the end of this session, I hope to offer insights into some of the challenges we encounter when working with adolescents and share what I've learned through reflection and experience. Just to give you a brief overview, there are many challenges we face when working with adolescents. So the first one is peers. So as young people transition into adolescence, their peers become a significant influence, and the desire to fit in can often impact motivation to engage with adults and professionals. In addition, they would have established long-standing learning histories of behaviours and interacting with others. This might not always result in positive outcomes. Puberty itself plays a critical role in shaping how teenagers impact both with their peers and their environments. The physical and psychological changes during this time can sometimes lead to negative effects on behaviours and relationships. Furthermore, it is essential we achieve buy-in from parents or caregivers, as this ensures the skills and knowledge introduced in therapy sessions are effectively generalised to other environments and they maintain over time. Boundaries are also essential. The young person must understand we are there to support them, but that our role is distinct from that of peers, friends and relatives. This is especially crucial when working with children who've experienced trauma or struggle with attachment difficulties. So our presentation is also important. For example, using age-appropriate language and being aware of how we dress can make a significant difference in establishing a therapeutic relationship. Even something as seemingly minor as understanding the latest trends can help with building trust and rapport. And if you're someone like me who's quickly approaching middle age, even keeping up with the latest trends can be a challenge in itself. So when working with young people, it is important these are considered, where it's essential to be creative and think outside the box, especially when we're looking to build rapport and develop a relationship. So these considerations were especially prominent when I began working with Dale. So just to give you some background information. So Dale is a 15-year-old female, as I mentioned earlier. She was placed into foster care at birth and she was adopted at the age of 1. Throughout her life, she experienced multiple adverse childhood experiences, which has a significant impact on development and well-being. So these ACEs include, there was significant generational trauma on the birth mother's side. So records indicated that the family had been known to social services for several generations, dating back to Dale's great-grandparents. There was also possible in utero alcohol exposure, so which may have contributed to developmental and behavioural challenges. So there's also family and sibling separation. So this would have occurred from when she transitioned from birth family and also then from foster care to adoption. Unfortunately, bereavement and grief played a part as well. Dale's adopted father passed away suddenly when she was 14 years old. And then finally, Dale was both a victim and perpetrator of bullying, which led to police involvement and referral to the youth offending team. So you can see there's a lot of complexities going on there when you're considering her current presentation, her history, and this needed to be taken on board to be able to develop trust and rapport for future therapy. So Dale was referred to the Behaviour Clinic. So there was a short-term goal of establishing trust and rapport and to build a therapeutic relationship to access therapy. And then it was a long-term goal of transitioning and engaging in therapy in a therapeutic setting and on a one-to-one basis. So the short-term goal was developed through 8 sessions being funded, but additional 8 sessions were requested at a later date to continue developing rapport. So to be able to assess Dale's current engagement, I attended the first session to her home. Just to engage with her and see where she was and to build from that. So it was apparent that her willingness to engage was limited and building rapport would require time. So during the session, Dale remained in her room. Her door was slightly ajar and I could see that curtains were drawn and she was lying in bed with the back to the door. So I attempted to engage with her by speaking through the door gap, but her only response was a shrug of her shoulders. I spent approximately 5 minutes in this initial interaction where I introduced myself, explained about my role and shared about the incentive system I had developed. However, I did make sure to keep the information brief as I did not want to overwhelm her. In addition, I emphasised that I wanted to respect her bedroom as a safe space and assured her that I would not enter without her consent. After those 5 minutes, I left the area and spent time with the mother to build rapport and trust with her as well. But even though there was limited engagement, I thought the session went really well. So, because I was expected to be screamed and shouted at and I had lots of items thrown at me. So, to maximise rapport building with Dale, I drew upon my knowledge of her history, her current presentation, and the unique challenges of working with young people and adolescents. So, to achieve this, several strategies were incorporated. So, this included dressing casually to present myself as relaxed and approachable. Dale was offered a choice between sessions and where they took place, for example, her home or at the local horse stables. Dale was allowed to have family and friends to join, so this was to help her feel comfortable, relaxed, and having a support network with her. And I also got a lot involved with activities. I participated in activities such as feeding and grooming the horse and mucking out the stables. So, but not only did it help to build rapport, it gave me the opportunity to learn lots more about horses, which I didn't even know before. So, but in addition to this, that I did also develop the incentive system, which was tailored to Dale's interest. But I'll talk about that in more detail now. So the incentive system was created to develop key skills necessary within a therapeutic setting, such as verbal communication and engaging on a one-to-one basis with myself. The skills were developed into session expectations, both for myself and her, as I felt this was important so that she knew that a therapeutic relationship was a two-way process. The expectations were carefully developed based on my observations during the first session and broken down into manageable steps. For example, initially Dale was expected to communicate by nodding, shaking her head or shrugging her shoulders, as she'd already shown that she would do these behaviours in the first session. And the minimum duration for each session was reduced from 60 minutes to 20 minutes. Over time, these expectations gradually increased, where Dale communicated using verbal responses such as yes or no, and the session duration increased to 30 minutes. Dale was then able to earn points for engaging in these behaviours, which were then converted in a monetary value, and she was able to purchase items of her choice. And to support with her progress, she was given her own tracker so that she could visually monitor her achievements. So, with developing the incentive system, I was really excited. I felt that it was really good and that I was like a proud peacock strutting, thinking that she was going to be really engaging with the system. But she engaged, but this was variable. This depended on her mood that day or if negative events had occurred during the week. She attended sessions, but would only stay for the minimum amount. And really, can we say that she attended if it was me arriving to her? Dale engaged with conversation, but again, this was variable, dependent on the mood and if any significant events had occurred. And Dale did agree to attend the clinic on one occasion, but she cancelled on the day. And there were many times that I was told where to go. I let your imaginations fill in on what words were used towards me on that day. So just to give you a snapshot of how sessions went, I've provided the graph on the screen shows the duration Dale attended the sessions. So the duration is displayed on the y-axis and the date is displayed on the x-axis. The dashed line in the middle represents the break between sessions where additional funding was requested. So as you can see, the duration Dale attended sessions varied, with the average duration being 34 minutes. The duration Dale attended was dependent on the session location, who was also there, and the duration stated on the incentive chart. So for example, between August and December, Dale stayed for the minimum duration of 20 minutes. However, these sessions were completed at home on a one-to-one basis, and the 20 minutes was stated on the incentive system. So it's important to note that Dale remained in session until the incentive was achieved, but then she left. So this indicated that there were flaws within the system, and also that even though she was engaging on some occasions, she was still struggling to display the skills needed, such as staying with myself on a one-to-one basis for a longer duration, and also engaging in therapy. So as a result, Dale did not transition to access therapy, and I no longer felt like a proud peacock. And as professionals, it is essential we reflect on our practice to learn from our experiences to continually improve our skills. By doing so, we can enhance the support we provide to the populations we serve and ensure we are meeting their needs effectively. So after reflection, there were many factors contributing to the effectiveness of the intervention, which I will talk about now. One such factor was the variability in Dale's mood, which influenced how I presented myself during our sessions. I was very conscious of the need to build rapport and ensure the success of each session, so I adapted my approach based on how Dale was feeling on the given day. So for example, if she was in a negative mood, then I would take a step back, but if she was more positive, then I'd be more approachable to her, and I'd be more upbeat and in an enthusiastic manner. But upon reflection, this shows that the session was being controlled by Dale and not by myself. Another challenge was the 3-month break in therapy due to a delay in securing additional funding for the extra sessions. So this break meant that when the therapy resumed, I had to rebuild rapport from scratch. So in hindsight, although requesting additional funding can take time, the delay might have been reduced or avoided if I had submitted the request to Dale's social worker sooner. I also encountered mixed messages from Dale's family, which also again impacted my approach. So there were times when the family was supportive and determined for Dale to continue with therapy, but other times they expressed uncertainty. So again, this caused me to fluctuate within my approach again, as I tried to balance promoting the benefits of therapy, whilst also being mindful not to undermine the family's confidence in the process. A delay in reinforcement was also a factor. So during the time the incentive system was being implemented, there were postal strikes which impacted the timely arrival of items. This in turn impacted the overall effectiveness of the incentive system. So as we all know, immediacy of reinforcement is essential when increasing positive behaviours. In addition, the plan of ordering and delivering items is also not effective, as I found myself in a constant cycle. Dale would earn her incentive 1 week, and then when I arrived the previous week with the item, she would disengage. So this left me in a situation where I had to provide the item that she'd earned, but I was inadvertently reinforcing disengagement. This also then led to broken trust, where Dale felt that I did not follow through on what I said I would do. So for example, like getting her items to her in a timely manner. Other factors that contributed were, so when looking at to increase engagement and familiarise Dale with the clinic environment, I sent photos of the clinic to her through WhatsApp. So however, I later received feedback from her mother expressing that Dale did not appreciate receiving these photos, and it made her feel pressured about therapy. So this then led me to adjust my communication strategy. So to avoid Dale feeling increasing pressure towards Dale, I refrained from communicating directly with her and instead communicated through her mother. However, in hindsight, this may have impacted rapport building, as Dale might have felt excluded from the process and that her feelings were not fully acknowledged. Additionally, in my desire to make the session a success, and due to pressure from various stakeholders, I became overly flexible with the sessions, the location and how they were conducted. Whilst flexibility can be beneficial, I now realise that boundaries and expectations should have been established clearly from the very beginning to ensure consistency and a more structured approach. Unfortunately, on one occasion, I was late for leaving a session, so I got my times mixed up and left at 12, and the session was supposed to start at 12. Yep, I know what you're all thinking, absolute tool. But yeah, I phoned Mum and explained I was late, but then Dale refused to see me, which I don't blame her. But to make it all worse, on this occasion, she was fully willing to engage with me and was prepared to complete a therapeutic task. And even now to this day, when I think back on that, I still want to kick myself about it. So, as we do with professionals, after reflection, we ensure to adapt and improve our practice. So to do that, I've implemented several changes to my practice. So the first involved reviewing the incentive system. So for example, once preferences have been determined, I pre-order items and develop a catalogue of choices, and then they can select from this, so the item is then delivered immediately. This allows for more immediate reinforcement by reducing delays to maintain engagement, and it also enhances trustworthiness when the young person knows I'll follow through on what I say. In addition, I seek support with problem solving if needed. For example, the issues with the postal delays could have been rectified with me going to the shop and purchasing the items instead. I also ensure my timekeeping is on point by setting up regular reminders and double checking my calendar to plan for my week or the day ahead. But also as well, I've made changes to my approach. So these include communicating with the young person themselves through the preferred communication method. This increases opportunities to engage and build rapport and helps the young person feel every effort has been made to ensure they feel listened to and valued. So, and this naturally increases trust and rapport and strengthens rapport. So another adjustment involves adding more structure to the sessions. So whilst, as I mentioned earlier, whilst flexibility is important for building rapport and increasing buy-in, I have found that providing a clear time and day and location for future sessions is crucial. So this structure helps manage expectations and ensures consistency for both myself and the young person. And I've also shifted focus away from purely tangible items and now place greater emphasis on the young person's motivations and needs. So for instance, I focus more on understanding what they want to change, what they hope to achieve from therapy, and tailoring the sessions to reflect their values. So, and this approach then not only meets the therapeutic goals, but also empowers the young person to take an active role in their own growth and development. Finally, and my last point of the session, I now ensure that clear boundaries are established and communicated from the outset. This includes defining my role as a therapist and outlining how I can support the young person. I also make it clear what is expected from them during sessions and help them understand how to make the most out of therapy so we can benefit them. So, and this is also as well communicated to other professionals. So this is to ensure I practice within my own boundaries. So unrealistic expectations are identified and managed. So that is the end of my segment. I'd just like to finish up by saying that it's really important that we learn from our mistakes to ensure we continue best practice and provide the care support needed for the populations we serve. So I've learned from my mistakes, and I hope this segment has helped you within your roles. Just before I leave, here is the all-important CEU keyword for those of you collecting CEUs, and the code word is riddle. But next up then is Barney Huxtable, and he will tell you about his experiences and his lessons learned when working within multidisciplinary teams. So thank you for listening, and I appreciate you taking the time to attend.
Thanks, Krista. Okay, so thank you, Krista. Thanks, Ethan, as well for the introduction. So as Krista and Ethan mentioned, my name's Barney Huxtable, and I am a behaviour analyst. I work at Behaviour Clinic within our team that directly supports residential services. So a lot of my work is involved with this side of things. So we wanted today to kind of introduce you to trauma-informed care and a little bit about the work that we do, and we wanted to then give some examples of how we've learned from a number of mistakes working with young people directly, but also I wanted to give a bit of an overview of working multidisciplinary and within teams, and how we've come across some challenges within this. And I think probably most people on this call, all of you on this call, will often work multidisciplinary, and hopefully we'll learn from some of my mistakes anyway. So before I get into the examples I'd like to go through today, I just wanted to briefly define what a multidisciplinary team is. So according to the Health Foundation and World Health Organization, a multidisciplinary team is a group of professionals from diverse disciplines who collaborate to plan and coordinate care for individuals with complex needs. These teams often operate within community settings, such as general practices, focusing on people requiring comprehensive health and social care. And I'm sure everybody on this call is regularly working within MDTs. We certainly are with the work that we do, and we feel that it's a really prominent part of our job, and something that can be quite difficult and throw up a lot of challenges, but something that, if done correctly, can really help improve quality of life for a young person. So when do we need to work multidisciplinary? Essentially, I think we need to work multidisciplinary a lot when we're working with children or adults, any people. I think working multidisciplinary, pulling on the expertise from different professionals is super important. When teaching skills, we need to rely on parents, teachers, other professionals there. When working in mental health, we see this every single day, every sort of hour that I'm in work. Our team is multidisciplinary, but it's super essential to do that when working with people with mental health challenges, and as well intellectual learning disabilities. And it's also really important to work multidisciplinary, I believe, when developing programs. A lot of our trainings, a lot of our therapies that we've created or set up, or the models that we've designed, have really brought in expertise and professional expertise from other areas of professionals, and not strictly sort of behaviour analysis or PBS, which is my background. And also when conducting research, there's some amazing research out there, but personally I think the best research is the ones which pull in lots of different areas and really look at sort of measuring and monitoring different approaches that draw upon a variety of expertise. So essentially, I believe that multidisciplinary working is needed all the time when working in this field, and I want to try and get across that and how we've done that within a specific case. Before I start, I'd like to just run through some feedback that I've received, which I think has been a challenge to overcome in itself when working in multidisciplinary teams. Let me just make this very clear. The way that I would have liked to respond was very different to the way that I did respond, but I'm going to talk you through my initial thoughts when these comments were made. So not too long ago, I was told that you just see a child as a data point. Now, I would love to have responded by saying, well, it depends on a research design. Someone else once told me, when I told them I was a behaviour analyst, no, they do not need a sticker chart. I would like to have said, well, I guess you're happy to work for free today then. Don't you think emotions are more important than behaviours? Emotions? What are those? I didn't say that. Why don't we remove a reward every time she is aggressive? Well, I'd love to have replied with, why don't we dock your pay for every silly question you make? PBS and behaviour analysis have taken us back to the dark days. This was a really tough one and evoked a lot of emotion and internal behaviour for me. I would have liked just to respond to tell them to turn the lights on potentially. Anyway, I'm going to circle back around to that as I go through the lessons that we've learned and how I've kind of managed to take this criticism over the years, and we'll come back to how I did actually respond. But just for those out there, I didn't actually say these things in the moment. Just protect my own professional reputation. So I'm going to introduce a practice example here, and if anyone was at Amy's talk this morning, I almost thought that we were talking about the same client, which she was an incredible talk this morning, and I learned a lot from it. But this client is very similar to those that were in that talk this morning. She is a 15-year-old female. She had experienced significant ACEs, mainly domestic abuse and suspected sexual abuse, which was intrafamilial. She also was diagnosed with mild learning disability and Tourette's, and with the exposure to those ACEs and those diagnoses, we saw a lot of behaviours of concern that really affected her quality of life presented within Sarah. So she would engage in quite intense physical aggression of a really high magnitude. She would engage in a lot of property destruction and a number of sexually inhibited behaviours, as well as a variety of self-harm. Her story came from she was taken into care following an allegation of sexual abuse within the family home, and placed into a residential home initially, where she, unfortunately, some of her behaviours became more intense, and we saw those behaviours increase to the point where she needed to attend a secure unit for about 18 months. After 18 months, she was then dropped down into a residential placement, which they had commissioned a lot of specialist support, and that's where we were introduced to support the team and to provide some therapeutic input to Sarah, with a very detailed deprivation of liberty safeguards in place, which included a 4-to-1 staffing. She couldn't go to the bathroom without a staff member being outside. She couldn't sleep without the door being open and her being monitored by staff. There was a lot of restrictions in place. She had a lot of restricted access to the community. She was unable to leave the house at one point. The house was also locked down, so she at one point during our time working with her, she was only allowed access to a front room and a bedroom, no access to the kitchen, no access to the bathrooms unless requested, and all of these safeguards were in place, which were really, really difficult for her and the team. So we trained the team in our tribe approach, and that's if you want to know a little bit more about that, I've chucked a QR code at the end for people to scan with more information. But essentially, it's a model of residential care, which includes a lot of PBS and trauma-informed approaches. So just to set the scene, this was Sarah. As you can imagine, Sarah had a very large multidisciplinary team. Due to the complexities and the amount of professionals that were involved, which was absolutely needed. She had some behaviour analysts, so myself and my colleague Jess were our jobs to work with the home, to provide training, to provide on-site consultation work, modelling, guidance for the staff within the home. She had also undertook Great Ormond Street Hospital psychological assessment, which recommended cognitive behaviour therapy, acceptance commitment therapy, and therapeutic life story work, which we were working through. She had a team of CAMHS mental health nurses, which worked with her and the home. She had an education team that would go in on a daily basis to provide education on site. She had a very competent and compassionate residential team, which received a lot of training and support. She had social services, she had a social worker, but she also had involvement from the principal officer and higher management within social services, and was very well known to kind of like the head of services. There's a psychiatrist involved managing her medication. There's a clinical psychologist who would do regular assessments. There was a health team involved due to some forms of pseudo-seizures, which they had linked back to trauma, as well as some epileptic seizures. There was we had regular meetings with emergency services. At a point, we were seeing the police, the ambulances, and the fire brigade called out on a regular basis. And she had an advocate that she would see regularly that would help to try and kind of push across her wants and needs. As you can imagine, I imagine pretty much everyone on this talk has been in these types of meetings with this intense support from a range of professionals. They're not always easy. This one was very difficult. There was a lot of different opinions on how best to support Sarah within the community and in this step down from a secure unit. And early on in those days, there was some quite difficult, some quite emotional meetings, and we learned pretty quick that we needed to adapt the way that we worked in this multidisciplinary team to get the best outcomes for Sarah. So there was a big clash. There was as PBS specialists, as behaviour analysts, we absolutely advocated for a least to most restrictive environment, especially coming out of that secure setting. So our approach was very much, how can we safely provide more access to the community? What reinforcement systems do we need in place so that she knows what the expectations are, what behaviours are going to pay off for her? How can we have that like non-contingent reinforcement available? And Amy talked a lot about it this morning, of actually she should have access to these nice things. If they need to be removed for safety reasons, then that's okay, but actually she should have access to that. And we were very much on that approach as well. We wanted to focus on skill building from a holistic approach. So we used behaviour skills training to teach staff to teach her independent skills, as well as natural environment teaching, to try and teach her a variety of skills which we felt would act as behaviour cusps, and she could essentially engage in behaviour independently, which would help her to access more reinforcement from her environment naturally. We were in full agreement with the GOSH assessment and were working through those therapeutic recommendations, and we felt that there was a lot of questions that she had unanswered that needed to be answered for her to be able to kind of process some of the trauma she'd experienced and be able to learn skills to protective factors to help her to build that tolerance. We very much advocate for a hands-off approach, and we had listed a number of precursor behaviours which often led to quite intense physical aggression or property destruction or more severe challenges. And our kind of approach was very much withdraw, de-escalate, try and avoid using any form of restrictive practice where possible. However, we completely understood that there were times due to safety that hands were needed to be put on, and that needs to be done safely. And our focus was very much on how do we repair, reconnect, help her to move away from those feelings of shame, understand that maybe some of the behaviours weren't acceptable or appropriate, but actually they weren't. She wasn't a bad person. She wasn't a bad person. And a real focus on relational work. So trying to get the teams to set up a number of activities throughout the day which would help form more secure attachments, to help her to understand that adults can be trusted and that we're here to keep her safe. We're not here to restrict or punish her. There was on the other side of the coin there, where there was a number of professionals within this within the multidisciplinary team that were recommending a very much a most least restrictive approach, and I completely understand where they're coming from after lots of sort of reflection and discussions with them. It was very much a safety point of view, and the recommendations were being given that actually more restriction was needed, more what we would call punishment-based interventions were needed, for safety reasons, and very much a hands-on approach. So if those precursor behaviours were seen, the initial recommendations from a number of professionals were actually we put hands-on straight away because we keep people safe, with the rationale that actually there have been staff members that were hospitalised, there have been staff members that had to leave due to some of the challenging behavioural challenges that were displayed. There was a focus on skills teaching, which we really loved and we agreed with, but the focus was solely on dialectical behaviour therapy and teaching distress tolerance skills. And we felt that actually there needs to be more just general skill building of her overall, which we're going to help her equip her to be able to reduce restrictions, access to community, improve her quality of life. And there was a big clash between the thoughts on therapeutic intervention. There was a number of professionals that thought the recommendations within the psychological assessment were appropriate and needed to be followed, and there was a number of professionals that felt that absolutely we should not be discussing any historical stuff with her, even if it kind of comes up in day-to-day practice, which was a conversation which often got quite heated. And yeah, like I said, we made many mistakes. We put our hands up. We made many mistakes at the start of this work. We probably became too emotional. We probably became too invested, not too invested. Don't think that's possible, but we possibly didn't manage ourselves in the most professional manner. So we had to try and overcome this, and I've highlighted a number of kind of bullet points and areas which we as a team, as therapists, as another consultant, and as a group of professionals, we came together to really identify, and since discussing these and implementing these into our practice, we found that the relationships, the multidisciplinary working has really improved, and therefore we've seen a lot more progress. So initially we identified our non-negotiables and our values as professionals. What do we want as professionals? What do we want for Sarah? And what were we not willing to budge on? Things like restrictive practice, being a last resort was something that actually we all agreed we weren't really willing to budge on that. So we would keep our recommendations pretty consistent when it came to that. We identified clear roles, and I think this was really important. And again, if anyone was at Amy's talk this morning, I know they talked about and identifying that clear roles around who was responsible for what, who was responsible for certain specific behaviours or interventions or parts of their care plan. We spent time, and this was really powerful, understanding each other's professions. So we went and presented to certain professionals, they came and presented to us. We talked about our education, our background, our experiences, and we worked out from there, like, right, what part of the care plan would we be best suited to manage? What part of the care plan would other people be best suited to manage? We were really aware of the language we used. I think this is a hot topic and it should be rightly so, but we were really aware of not using any sort of behaviour analytic or technical language within meetings. We tried to use language which could be understood across no matter what your profession was. And we communicated that it was okay to disagree. And this was a real turning point when we sat in a meeting and we said, actually, do you know what? We've got a lot to bring to the table, and it's okay to disagree. And professional doubt or philosophical doubt, whatever you want to call it, is a really important part of making sure we're acting in the best interest of Sarah and the client here. And we always took it back to the question of what is in Sarah's best interest, what does she want, what does she need? And I think by bringing it back to those values and really trying to take it back to what does she need from this, what does she need from us, what's in her best interest, really helped shape and hone in on us as a team working together, and a big team at that. We tried to refer back to assessments, goals, and any evidence that we had gathered during the time working with Sarah, or still working with Sarah, and we tried to use those as guiding documents and use those assessments to really evidence like why we were doing certain things or why we were challenging certain things, and tried to preempt things that might cause offence. So being really aware of, actually, like, I don't fully understand some of other people's profession, and that's okay, but actually kind of doing that in a very non-judgmental or non-threatening way of saying, can you help me understand this a little bit? I think I've got the wrong end of the stick. Please, could we have a chat off meeting and just talk me through your recommendation here, so I can understand it a little bit better. And that seemed to work really well. And then regulating our own emotions, being aware of our body language, our facial expressions in meetings. I think in real life that's quite easy to do, but in 2025, where most meetings are on Zoom or Teams, can be quite easy to let your facial expressions run away from yourself. So we as a team, we discussed how that was a really important element. And actually, like, when recommendations came up which were alien to us or we didn't understand, we were compassionately questioning them and not coming about that from a maybe less professional approach, which is easy to do. So the outcome was great. So each professional has their expertise that they focus on, which works really well. And what we found really helpful was we communicated that to Sarah. So at the start, where we were kind of working out who does what, she would become very confused. And I mean, we were confused about who was doing what. So how this made her feel, you can only imagine. So we communicate with her that we were in charge of these certain parts of her care plans. Another professional was in charge of other certain areas. We'd have regular reviews of these roles where we would really almost like outline them and have a visual of, okay, Barney's going to look at this, so just going to look at this. And where we did disagree, we always took that back to the stakeholders, which in this case was the local authority, to say, look, this is what I think. I'm not really willing to budge on that. This is what other people think. This is what other people think. Here's kind of all our thoughts, all our evidence. It's kind of your choice now to make this decision in the best interest of Sarah. And a lot of the time we were saying the same thing, but we were using different language in those early days, which would become very confusing. We soon learned, actually, we probably agree with what you're saying, but you're using different language that we need to kind of just understand or learn, maybe. What we found is Sarah continues to make progress. She certainly started to make more progress when professionals work together. And although we don't always agree, I think we're at a stage now where we are able to look at it as what's in Sarah's best interest, and actually as an MDT, we still get it wrong every now and again, but starting to get it right more than we got it wrong in those early days. So I'm going to circle back around to the comments that, the criticisms that I've experienced, and I'm sure many people on this call have experienced similar, and talk about how, from what we learned, how we did respond to these. So you just see children as a data point. That hurt quite a lot, but I was able to kind of acknowledge that I'm sorry that that person had felt that way, and I kind of wondered whether they'd had any experiences of bad practice from a behaviour analyst or a PBS practitioner in the past, and I'd love to explore the data with them a little bit more, because I felt that actually some of the data we had collected in this example could have been really helpful for the work that they were doing, which it was. So behaviour analysis, no, they do not need a sticker chart. Well, I would absolutely agree with that. Very rarely has a sticker chart ever changed many of the behaviours that we work with, and the chance and it takes a little bit more than a sticker chart, as we all know, and also it needs to be implemented correctly if we are going to run any form of reinforcement or token economy. So I would respond to that by saying I would agree with them on this one. We don't need a sticker chart, but I think we could look at the motivators that are in place for the child, so that they are aware of the expectations under different contexts, and ask if we can talk about it a little bit more and see if actually some of the principles of PBS, principles of behaviour analysis, can help in this case, because I strongly feel that we have a role to play. Don't you think emotions are more important than behaviour? Absolutely agree with that. I agree with emotions are extremely important. Emotions can act as a motivator or an abolisher for certain behaviours, and maybe we can try and get our heads together to look at how emotions and behaviours work together, or in this case actually work against each other, or how the person's environment is affecting how they're feeling, and therefore some of the behaviours that we are seeing. Why don't we remove a reward every time she's aggressive? Again, I responded that with compassion. I understand why you would think that. I understand why that would be a kind of go-to response to some of the behaviours that we're seeing. But to play devil's advocate, I think we need to consider, actually we're seeing a lot of aggression at the minute for this person, and actually if we were to remove an item every single time, we are going to get to the stage where she doesn't have anything in her bedroom or anything available, and then where do we stand? I also would like to kind of bring to the attention that we're talking about a person who's experienced significant trauma, significant punishment, significant physical aggression and domestic violence, and actually by removing these items and responding in that way, which is essentially playing out what she's been modelled to her, are we potentially supporting kind of like a re-traumatization, or actually in compounding some of that trauma, and do we need to look at this from another aspect? I would agree that we don't want to be providing rewards straight after challenging behaviour, but also we need to have a nice and trauma-informed approach to how we work. So this one was a real bitter pill to swallow. PBS and behaviour analysis taking us back to the dark days, and that is quote word for word. And I did struggle to respond to that one, but the way that we looked to respond was, it's a really interesting comment, and I'd like to know more about what makes you kind of think this, and maybe we've worked with or heard of some bad practice across behaviour analysis, probably more than PBS, but behaviour analysis in the past. And can I tell you a little bit more about what we do, or what I do, or what my values are as a professional, and can we explore this a little bit more, and that belief. So yeah, to save my professional reputation, that is how I responded to these questions, and not as per a few slides ago. Okay, so your final CEU word today, or CPD word, is Dumbledore. You can tell Krista has put the images on this one. I'll give you a couple of seconds, and then I'm conscious of time. I'll just quickly sum up, and there's time for some questions. So yeah, so just to summarise the three talks today from us, I think I believe and we believe that a one fit approach doesn't always work, and actually an integrative approach is normally the best. I'm very wary of anyone who kind of says that one way is the only way. I think we've got so much to learn from so much amazing work going on out in our field, whether that be from speech and language therapists, from mental health specialists, from teachers. I think we've got so much to learn. I think learning to appreciate feedback, even where it isn't that positive, is really important. And I think our field is always moving. I know certainly if you told me the things that I was practicing 5 years ago, they'd be completely different to how I practice now. And I hope that in 5 years' time, I would have learned more again and probably will be practicing in a different way. And I think we just need to keep moving with our field. I think philosophical doubt or professional doubt, whatever you want to call it, is all great. And we should always ask our question why, even when I'm putting that intervention in, why am I doing that? What is the values here? What is the evidence here? What is this the right intervention for this person? And I think to sort of paraphrase Greg Hanley and just say always practice as if you are on film. And I think if you do that, the chances are your practice is going to be compassionate, ethical, and empathetic. And that's absolutely a message that we try to send here. So thank you so much for attending our talk, and thank you all for doing such an amazing work in our field. And I know there's lots of different professionals here on at this conference, and it's I think it's been amazing so far, and it's great to hear so many awesome stuff. I've just chucked a couple of QR codes on there, so I can't talk about feedback and then not ask for it. So the QR code in green on my left-hand side is if you wanted to give us some feedback on this talk, and then the other QR codes are information about the Behaviour Clinic and the tribe model as well. But sorry, Hugh, I know I'm supposed to leave 10 minutes at the end, but I can stick around if anyone has any questions. Krista and Ethan are also here still.
Wonderful, thanks, Barney. You know, one thing that I was going to say is that I have a question, but it seems slightly unfair that I put myself at the front of the queue. So if you're happy to run over a little bit, that would be cool.
Yeah,
so I myself. You had quite a lot of feedback as we went along for all of you, just in terms of quite a few people just commented on how brave and frank some of these cases you discussed were, and how refreshing it is for people to be kind of honest in their reflections on some of their work, and some of the comments about how much people have appreciated the extent to which you're trying to implement reasonable adjustments for people that you're supporting. And I guess I just wanted to add on that it's not an easy ask to say to people, we'd like you to reflect on your mistakes. You know, come and tell us what hasn't worked. And I think that's what I really, really enjoyed here. Actually, it's really interesting and really refreshing having people kind of saying this didn't work, and we thought about why, but fundamentally, you know. So let's jump into some of the questions. I think we had one quite early on about with respect to Sarah, this kind of idea that some parties were putting forwards that they felt punishment or restrictive approaches were important. The question kind of relates to motivation, I suppose. They were kind of asking whether there was a high level of staff anxiety, and whether you guys felt that actually it's that anxiety that was maybe resulting in people kind of moving towards aversive or punitive procedures.
Absolutely, yeah. I think it was so for those, sorry, I don't even know if Amy's in this talk, but I keep talking about a talk. It was really great this morning. But for those that went to that one, she described a really great process from secure down into kind of like a drop down. We went from a secure setting down to there wasn't much prep done, and I don't think the staff team were probably equipped to manage some of the intensities of the behaviours that we saw. So we were training on site. We were almost chasing our tail on it the whole time, and it took a long time to catch up. And there's a lot of learning to be done from us, from local authorities, from all professionals within that project. But I think there was a lot of anxiety around, and I think unfortunately, I know that's not the case in this conference, but I think unfortunately we still see in our field that the go-to is safety, and by safety they mean restrictive practice, which I strongly disagree with. But I think unfortunately that was probably the easiest option and what looked like the safest option. I know again Amy talked about like having that standing off, and when you've got a young person engaging in really intense behaviour, self-harming, standing back and trying to kind of de-escalate is not your whole the human nature is to do something at that point, isn't it? But what we truly believed and what we saw was, if you held back a little bit, if you talked this young person through what was going on, if you were able to de-escalate, she actually the behaviours wouldn't escalate to the level they would. But that took a lot of convincing, training and exposure for staff before they kind of got the hang of it. And then unfortunately there was such a clash between the recommendations. We did have a lot of professionals kind of coming in and saying, no, you shouldn't be doing that, you should be putting hands on straight away. And then and there was a very much a mixed message with the staff group. So I think, I don't know if I've answered that very well, but
No, I really think you have. Thank you. Just to let you know, a couple of people have highlighted Amy is here.
oh, sorry, Amy.
They've also highlighted that she's asked a question in the chat that I've got my kind of list going on, guys. I'm afraid, like queuing system going on. But let's jump to Amy's next, which is a really good one from my perspective, because one of the other things that I was going to say is just how relatable that description of the difficulty navigating multidisciplinary teams can be. And Amy's question does relate to that, which is about buy-in, basically. You know, how did you get buy-in from the other professionals just to spend time together and try and understand one another's professions, roles, approaches?
Yeah, great question. Again, and it goes back to something Paddy said in the talk just that I went before. We spent time with the group. We were there. We didn't necessarily go in and tell them what to do from day dot. We spent time. We got to know the staff team. We listened to their challenges, and I think that was like mega. As in, like, there were so many professionals involved, and to this day, we've got a really good relationship with the guys actually doing what we're asking them to do on the field. And I think that taking that time, going and spending half a day there, actually listening to the concerns was like super helpful to get buy-in from that side of it. Again, we tried to over deliver with the other professionals. So if we said we were going to do something, we tried to get it done within the time frame we said we were going to do. We tried to be consistent with our approaches, and we just tried to put the effort in where we would set up meetings, we would invite people to the clinic, we would go to their offices to discuss things. And I think those really I think they're probably like missed a little bit, but those soft skills, or I don't know if we call it their soft skills or not, but those softer skills really helped with building that rapport and that relationship, and really understanding it. Me and Jess and Katie and Hayley, who I think are on the call, who worked on it, we really took time to try and understand why these recommendations were being put in place, like what their history was. We didn't know anything about hospitalized settings, or we know a bit about secure, but a lot of the professionals come from hospitals. We didn't know anything about that, so we tried to understand what that might be like and what their experiences might have been, so we could actually kind of like understand where these recommendations were coming from. And then we just tried to compassionately push our views on it, which didn't always work, but I think we've done a good job with most of the professionals in that team.
Great, thank you. Yes, I was immediately thinking of the panel that Paddy hosted, and just that kind of concept. Your most important commodity is time. You know, giving people time is valuable, and I think that applies, you know, across systems, really, whether people we support or other practitioners or family members. I think that's a great point. I also, I'm just kind of segueing in my own views between questions, but if I don't say it whilst I think it, it'll never come back to me. But I just wanted to also kind of highlight that point you made about, you know, when receiving kind of critical views on ABA or PBS or whatever, the importance of that constructional approach in terms of listening first, but the kind of key words that I'd link it back to in terms of what you were saying is compassion. I think sometimes people are tempted to just jump straight to the defensive. You know, this is what the literature says, or that's not my practice. My practice.
Which always goes down well, isn't it? Go read that.
I just think sometimes we miss the importance of hearing people.
Absolutely, yeah.
If you don't hear them first, they're not going to listen to anything that you've got to say. And actually, from my perspective, wherever that criticism is coming from, the first thing should be to tell me more about it. I'd like to listen. You know, I'd like to understand why you feel that way. But I thought that was a great point. Okay, next question. This is a good one, I think. So, broadly talking about kind of organizational change, I suppose. So both in terms of changing some of the views of other professionals, but also I suspect here it relates back to that kind of point about changing some of the views around things like punishment, restrictive practices, etc. The question is, do you feel that one of the biggest barriers here is response effort, i.e., the amount of effort it takes to make that change? If so, what adaptations can be made to reduce the response effort for other professionals to change?
Great question. Anyone like to take that? I would absolutely agree. I think we can explain it from sort of the principles of behaviour, can't we? I think to stop a behaviour, it's a lot easier to jump in and just stop it than it would be to actually work, and behaviour change takes time. How you change that is a really, really difficult one. I think it goes back to rapport and relationships and trust. I think if you have rapport, you have a meaningful relationship with those staff and that team, and they trust you, I think you're a lot more likely to get that buy-in, and they're more likely to trust your recommendations and the long-term process of seeing behaviour change over a longer period of time. It's really hard to pinpoint, but for me, I think that's that. I don't know if you guys would like to add to that.
Yeah, I find like with my experiences of working with parents and carers, they instantly go to like the punishment strategy because it is more instant, it's easier for them. Whereas like where it is long term, where we increase in reinforcement, where you skill building and developing, it does take longer and they don't see those effects immediately. So I think I'd agree with the comment, like it is sometimes like the response effort to use restrictive strategies is easier. And you do get that immediate behaviour stopping. So yeah, I think it is partly to do with that. And like Barney said, it's like getting them to build trust, building rapport with the professionals, and getting them to see like the long term goals. So, and that's a kind of like to have sometimes when working with parents and carers as well, especially when they experience the challenging behaviours day in, day out. And they always miss the point, they always miss like the tiny positive little behaviours that are happening. So there's a lot of times where I get, oh, but they're not doing anything positive. So I was getting them to reflect. And I think that would be the same as working with professionals as well and multidisciplinary teams, is like getting them to reflect on like what behaviours were they displaying when they first came? Has that reduced? Has anything changed even? And then like getting them to pinpoint those tiny little differences, and then to like get that momentum for them then, and to build that up for them to be able to continue and use the reinforcement strategies. So I hope that helps answer.
Yes, yeah, no, thank you. And I think between you, you've given a really comprehensive answer. I guess another of the kind of takeaways for me from your presentation as a whole is you did come to kind of mention Greg Hanley towards the end, and I was just thinking that in terms of some of the key values that are kind of embedded within what you were talking about, particularly that safety, and not just staff safety, but all round safety for everyone. You know, trust and rapport. And again, I think that applies for professionals as well. I think it's a similar thing in terms of that kind of concept of people saying, no, thanks, we don't want this, or I've heard really bad things about this. Well, actually jumping on the back foot immediately, you're communicating there is no trust here, there is no safety, you know, because you're not allowed to voice your opinions. And actually, we're not going to have rapport because we're just going to give opposing views to one another rather than kind of focus on, I'm going to listen to what you've actually got to say and your concerns. With that in mind, my question's quite contentious. So I wanted to kind of mention the importance of safety first and give you the opportunity to decline, I'm not asking it to make a point. I would just be asking it just because I'm interested on your own reflections on this. But is that okay with you guys, or would you rather actually we've kind of had enough of the humility today and
No, you go, absolutely.
not practice anymore? Thank you very much. And again, the other thing that I should kind of highlight is, this isn't my kind of specialism. So, but I guess I was just interested with Dale's case in particular, at the idea of using a kind of extrinsic motivation system, so that kind of incentive system. And I just wondered, and it is something that comes up in some of the criticisms of behavioral approaches too. But I wondered whether potentially that inadvertently communicated to the young person, you shouldn't want to be here because actually we're kind of there's something here which will give you just for attending. That was one thing that I wondered, and the other thing I wondered, I suppose, is whether that also potentially creates some pressure in terms of you've got to stay if you want this thing, you've got to stay. And again, I suppose in some respects, because you reflected on this and you said less reliance on tangibles and also thinking more about the kind of non-contingent stuff. And I guess I was also thinking about that in terms of, we some of the Greg Hanley work in terms of actually we make this stuff available. I guess to kind of get away from the bits where it seems like I'm, being mean. I guess to frame my question is, do you not think you maybe could have more trust in your rapport building? Because I guess like that was the big emphasis, the important thing. And I think sometimes I personally get really anxious about that. And I get all those kind of, oh my God, what if they hate me? What if they don't like me? What if I completely fail? And then I kind of get into it and I think I should trust in this more. Actually, just trust in the fact that actually, if you give someone that I'm here for you, nothing else, and I'm interested in what you're interested in, that actually usually that goes a really, really long way. I'm not convinced that was even a question in the end, so much as a ramble. But I'm going to hand over to you guys. And
No, to be honest, I think you kind of hit the nail on the head where you said like, were you to feel anxious? And that's exactly how I felt going in, starting these sessions, because there was a lot of, I didn't really go into too much detail in the presentation, but in the background, there was a lot more pressure from other stakeholders in like, where they like, she really want to engage with you. How can you do it differently? How can you do it better? And to be honest, at that time, I never failed in having somebody engage with me. And I think she is the only one I've managed, and I still love the opportunity to go back and redo it all again. But no, and like, yeah, I was anxious. There was a lot of pressure there, and that was just too much influence on. Like you said, didn't really trust the process enough because my own emotions were impacting my own anxieties. Whereas now I learn now, like, right, take a step back, don't get overconfident, wait for the data to come in and to be able to see where this going and see the effectiveness. Whereas like at the start, I was really overconfident in the incentive system. So it's just like really taking a step back, really focusing and looking in and just like wait for the data to come in before getting overconfident or knowing when you need to make those changes. But you hit the nail on the head yourself here. It was just a lot of anxiety just going into those sessions anyway because of the pressure from stakeholders. So, but yeah.
I really, really appreciate your honesty there, Krista, and I think that is a great answer. And it also links in beautifully with some of your kind of other points. I very briefly mentioned kind of relating to the difficulty navigating multidisciplinary teams, but exactly as you say, actually often the networks around the people we're working with are bigger than that. And sometimes compromise is important. Actually it can't just be a matter of it's my way or nothing, because exactly as you've said, that buy-in is really important. But also sometimes I think it's kind of thinking about the pressure that's placed upon the practitioners ourselves, in terms of actually people expect results here. The difficulty is we're creating a pressurized system. And, I'd argue that the things that we're trying to do in these sorts of situations, rapport, trust, safety, being under pressure doesn't really help anyone achieve that. I think
I absolutely agree. Absolutely agree.
that's
Yeah.
also true of staff. That very often they're under pressure to kind of succeed.
Yeah.
Go on, Barney.
No. I was just going to say I absolutely agree, and I suppose don't need to add to that is I think we're often taught, aren't we? Like, right, what's the reinforcers here? How can we get this child to engage? And we often forget that, like, what are these kids' values, right? What? How can we? It's that metaphor of like, how can we pay into this account? Because in 10 weeks' time, when I ask them to do something, they're going to be a lot more likely to kind of like engage with me if I have really taken interest into them. I've identified their values. I've got these kind of like shared interests, and we've learned that massively over the last few years, especially with the kids we work with. Like, trust, safety is so important, and if you haven't got that, you haven't got anything. I don't think.
Thank you so much, guys. I really appreciate it, and I really appreciate you putting up with my difficult questions.
Good
think
question.
just shows that I took a lot away from your talk. So thank you again.
Brilliant. Thank you.
Thank you.